Okay. So, hi everybody. Thank you so much for joining our talk this evening. My name is Jyoti Nanda. I work with Xyle Plus. You must have seen my name on all your email correspondence. And so basically, I just wanted to do a quick snapshot of our agenda today. Basically, we're going to move into the talk, probably like 30 to 40 minutes. We'll leave some time for the Q&A at the end, but if your questions are relevant, I'll ask Dr. Holzberg as they come up if they're relevant to the slides. So just be sure to pop in your questions as they come up because we might answer them like right on the spot. And then after the talk, after the Q&A, we're gonna do a quick raffle. So if you're interested in that, be sure to hang on. It'll take just a few minutes, but if we call your name, we need you to be there so you can claim your prize. Other than that, just a reminder that the talk is being recorded and the replay will be available early next week, so you can watch it or you can share it with your peers. So yeah, so you'll have that, and then you are going to receive a certificate of attendance at the end of the talk sometime tonight, if not early morning. So keep an eye out for that. Okay, so with that being said, I just wanted to give you a quick introduction as to why we decided to do this talk. A lot of you are familiar with our UTI, overactive bladder, iron deficiency talks. And as much as we love to do those, we understand that there's only so much you can do for your patients without incorporating that optimal bedside manner, right? And so that's something that we really wanted to, if anything, give you a refresher or help you to learn some new things that you haven't really taken into consideration before. So, we're really helping you get a lot out of this talk. And it's completely unbranded. We're not talking about any products, nothing like that. So it's total just, helping you help your patients. So with that, I wanted to pass it on to Dr. Holzberg and let him introduce himself.
All right, thank you. Well said. So thanks everybody. I'm happy that we have the numbers that I can see so far that have joined. Hopefully this will be an interesting topic. So let me tell you a little bit about myself. So I am a urogynecologist, so it's not coincidental that a urogyne is giving this talk. I am an avid user of a lot of the products from Xeo Plus, and use them. I was just telling you on a pretty regular basis for recurrent UTIs. But we aren't going to be talking about today. But what we are going to be talking about is how our ability to connect with our patients can actually help them to get better. And that might be including using these types of products, but being able to connect with our patients and how that can improve their outcomes. Um, so so I am a urogyne, been doing it for about 25 years. I am currently in New Jersey, where I have been for quite some time. I'm an OBGYN resident trained, and then did fellowship in urogyne down at Cooper Health System, which is down in Camden, New Jersey. I was there for 25 years, sorry, for about 20 years. So most of my career, where I trained there, remained there as a division head for urogyne, started getting into some other leadership roles, clinical documentation improvement. But one of the roles I got into about 10 years ago really led me to where I am today. And that was when a organization came into our health system in order to change the health system's culture. And part of that change included improving the patient experience, improving provider engagement, which is really needed to improve the patient experience. And I was asked to lead that provider engagement part of that effort. I didn't know much about it at the time, and I really kind of lit a fire, and it really pivoted a little bit of my career into from clinical work, which I still continue to do to this day, and that's with Inspira Health, where I do practice urogyne on a somewhat limited basis, but I still do actively practice. I'm still currently doing surgery. That may be weaning down at some point, but I'm still actively doing surgery. And in between those places, I was a chair of OBGYN at our osteopathic medical school at Rowan University. So with that experience as a leader in provider engagement and patient experience at my health system, probably about 3 years ago or so, I contacted the people I was working with at Cooper, more or less as a client of the organization that came in as consultants to our organization and said, hey, I want to do this on a bigger scale than just my local institution. They knew my work I did at Cooper, and I ended up becoming a physician coach. And that is part of what I'm currently doing. I'm working for this consulting firm that had come years ago, and I'm acting as a physician coach now. And basically, what I do is I help providers of all kind, mid-level providers, physicians, to improve their ability to communicate with patients. I do it via direct observation and real-time feedback. We do it via didactics. We have many different methods of helping physicians improve their communication, and we're going to talk about a lot of that today. I am based down in Ocean City, New Jersey, which is on the shore of New Jersey, the southern Jersey shore. To my right, to the right of here is my wife and our five blended family children, each with dogs. So you'll see a few dogs in that picture as well. We live, like I said, down in Ocean City, and we do spend some time. We have a second home down in Florida, so we go back and forth a bit. So that's kind of my story. That's why I'm doing this talk. It's not because, and I'm going to talk a lot about the science behind all this, but it is because I began to do this work at my institution and now, get to do it. And like I was saying earlier, I've done it, within the United States, and I've done it within Canada. I've had clients down in Nova Scotia Health, and so I'm familiar with some areas of Canada and working with physicians on these very topics. So it's exciting to be able to talk to you guys about it. So anytime we talk about a topic, you have to understand the why behind it, and why is communicating with patients important? Why is communicating well with patients important? Well, let's talk about what we think our patients want, right? Do our patients want a provider that has the, top-notch training and experience? Yeah, they do. They want somebody with a lot of experience. And this was a Harris poll done many years ago, but I think still applicable today, that asked patients, what qualities do you look for in a physician? And 27% said, oh, I want them to have gone to the best medical school and best residency fellowship, and I want them to have been practicing for many years. But actually, what they really wanted was a physician who actually cared about them, was willing to spend time with them, listen to them, was easy to talk to, treated them with courtesy and respect. That was actually more important than the training and their experience. They wanted a provider that was compassionate, and that's what mattered to them. Sorry, I'm just trying to get rid of this banner here. There we go. Oh, no. All right, there we go. So the BMJ, the British Medical Journal Open, did a kind of a meta-analysis about 10 years ago, looking at all of the articles that talked about basically patient experience. And they found, and there's much more now studies that all do show a similar percentage of association, but they saw that they looked at 55 studies, and what they found, that patient experience, so the experience the patient has during the interaction with you, was positively associated with clinical effectiveness, so clinical outcomes and patient safety. So there was that direct correlation. So that's why this is so important. In the end, we want to have good clinical outcomes and take care of our patients in a safe, efficacious manner. Well, in order to do that, we have to have patients that are engaged, and we're going to talk about that, and feel that they've had a good experience. And looking at those articles, almost 80% showed a positive association between patient experience and clinical safety and effectiveness. About 22% showed a neutral association, so no direct correlation. I think there was one article that showed a negative association, but that was just one out of the 55 articles. So this is part of the why, right? Because if we provide a good experience for our patients, we'll be able to treat them in a safe, effective manner. Well, why else? Let's think about malpractice. Malpractice, is everywhere. Maybe a bigger problem here in the US than in Canada, for various reasons. But still, I know becoming more common of an issue. And what they found was, look, patients that have less satisfaction with their interaction with the institution or their physicians are more likely to have complaints. And patient complaints are more likely to predict malpractice events. Patients don't typically sue their provider or the institution because of a mistake. They sue because they are angry. They're angry because they were ignored, they weren't listened to, they weren't taken seriously. That's often why patients sue. They understand that mistakes can be made. That's not always the reason why they end up, litigation ends up occurring. It's often because of the factors we talked about earlier. Were they listened to? Were they treated with courtesy and respect? Did you spend time with them? It's that type of stuff that makes them upset. And then when the mistake happens, they somehow retaliate in that manner. So what's in it for me, right? So whenever we talk about, look, okay, we understand the correlation between patient experience, clinical outcomes, safe, effective manner, but how does communicating well with a patient and giving them a good experience help us as providers? Well, the classic teaching has always been, look, if we're over compassionate, if we lean too much into our patients, right, we risk burnout, right? Keep your patients at arm's length. Don't get too personal with them. Don't get too attached to them, because that's going to lead to more burnout. It actually, looking at the literature on this exact topic, what was found was the exact opposite. Actually, the more we lean into our patients, the more we connect with them, the more we learn about them on a personal level, the less burnout we have. So it totally debunks the thought of, don't get too close because you'll burn out. It's the opposite. And why? Why do you think it's the opposite? Well, because when we lean into our patients, we actually get more fulfillment in what we do. Patients tend to thank us, appreciate us more. We develop a relationship. We go home that night and say, wow, we met this great patient and we learned this about them and that about them. We enjoy what we do more. We remember our why, and then we have less burnout. So that's what you get yourself. So if you're interested in this topic, there's a couple of books. One of them I'm going to talk about is called Wonder Drug. It was written by colleagues of mine at Cooper. Steve Treziak is the chair of medicine and runs the Adult Health Institute. Anthony Mazzarelli is an ED physician, and he's the co-president and CEO of Cooper. But they, without getting too far into the story, they wrote an initial book called Compassionomics. Compassionomics, I would write it down if you're interested in the science behind this. They did a huge meta-analysis of compassion in medicine, and said at the time, look, we can't just tell providers to be more compassionate. We have to give them the science behind why. And they wrote Compassionomics. Then they wrote Wonder Drug. And Wonder Drug, also looking at that same science, found, okay, so being compassionate, we've already talked about, helps the patient, clinical outcomes, patient safety, all of that. But what does it do for the provider? It actually, being kind and compassionate, serving others, is the best medicine for ourselves. It activates a reward center in the brain that brings about positive emotion. This has been shown scientifically. It shifts our nervous system to a state of calm, so we're less anxious, we're less stressed. It has pain relieving effects. So being giving and kind and compassionate, and it's not just in medicine, by the way. This book focuses on being kind in general, in our work, in our families, in our life, that the more kind and compassionate we are, the more successful we are. And obviously, but then also the more professional fulfillment we have. The one caveat is the asterisk on the bottom there. You can't just fakely be nice, right? It has to be sincere, right? You have to be sincerely other focused to get all of these benefits. So it's not just beneficial to the receiver. Being compassionate and kind to our patients is not just beneficial to the receiver, but hugely beneficial to the giver, both in medicine, reducing burnout, and in life, just being more successful. So in general, why is connecting better? Well, think about it. If we connect more with our patients, we get to know them, they get to know you, they're going to be more forthcoming with information. It's going to improve efficiency of care. It improves quality. It improves survey results. In the US, we have monetary rewards and reimbursement linked to our patient experience. So for institutions, it helps them monetarily, reduces burnout. We talked about that, and reduces malpractice. So many reasons why connecting better is important. So I wanted you to have that framework of, I'm not just telling you to be nice and compassionate to your patients. I am, but I want you to understand why it's so important. So in general, right, we want to drive our patient outcomes. So by making that connection and connecting personally with our patients, during our interaction, not just caring for our patients, right? As providers, as physicians, we that's our job, right? Our job is to care for our patients. That's an expectation of our patients, that when they come to see you, you're going to care for them. You're going to diagnose the problem, hopefully get them better. But what they're judging you on is how much you care about them. That's the differentiator. And when they realize that, wow, my physician's actually not just caring for me, they're caring about me, their anxiety levels go down, you make that connection, and that drives all these outcomes. So a little bit about surveys. And this might be a little bit more for the US people that are in attendance, but our surveys, we have national surveys that are required by our hospitals, both inpatient and outpatient, and they generally revolve around three aspects. And this doesn't matter whether it's for surveys, and I don't speak to this. The reason to connect with our patients is not to improve surveys. But what I tell people is, look, the only way to know whether we're doing it right is to do a survey. So it's like when we go to medical school, we don't learn how to become a physician so that we can pass the test. We learn it so we can take care of patients. But the only way to know whether we learned it correctly is to take a test. So our surveys are like the test. And what they basically say is, did we treat our patients with courtesy and respect? Did we listen? And did we explain things in a way that was easy to understand? So if you take these three aspects and keep them in the back of your heads as you're interacting with your patients, am I explaining things in a way that's easy to understand? Am I listening, right? I'm not cutting them off mid-sentence. I'm waiting for we'll talk about this later, but I'm waiting for the question mark or waiting for the period. And did I treat them with courtesy and respect? And when they answer those questions, these are typically the way they're answered, always, usually, sometimes never, yes, definitely, mostly, somewhat, no, and then 0 to 10. The goal is to get the green. Always yes, definitely, and a 9 out of 10 when you're asking them 0 to 10. We call that top box. So our goal, and if we get anything below that, honestly, we failed. We didn't do what we were supposed to do. So doing all this, the goal of all this is to engage our patients in their care. Think about it. When we have a patient that's engaged in the care, they want to be involved, they want to participate, they want to go home and check their blood pressure, they want to modify their diet, they want to check their blood sugar, they want to give you feedback, they want to commit to lifelong changes. How much easier is it to take care of those patients? Much easier, because they're involved. The more engaged patients that manage their own care end up having better clinical outcomes. And the way to engage them is, we're going to talk about how to connect, how to be more compassionate, how to be more empathic with our patients, is how to get them to be more engaged. Okay. So why does engagement matter? Well, think about all of the things that get our patients better. All the modifiable behaviors, right? So 40% of deaths can be caused by modified behaviors, right? Diet, taking their medications, right? Keeping up with follow-up appointments, seeing referrals, right, that are recommended. These are all behaviors that occur because a patient's more engaged. At least we think so, right? The more engaged a patient is in the care, the more likely they'll take their medicine, the more likely they'll go to a follow-up appointment with you, the more likely they'll go to a referral that you recommend, or the more likely they'll modify their behavior, their diet, or any other aspects you ask them to behave. So there was a professor, physician, Dr. Hibbard, who said, okay, well, let's see if we can measure patient engagement. And she called it the patient activation measure, the PAM. And she created a survey that was able to measure that. And it divided into level 1, 2, 3, and 4. I'm not going to drain the slide, but level 4 being the highest meaning a patient who's highly engaged, adopting new behaviors, versus a level 1, very disengaged, knowledge is low, very poor adherence. So this survey was able to categorize them into level 1, 2, 3, and 4. Then they looked at various things. They looked at blood levels of HDL, triglycerides. They looked at whether people went for their preventative care, pap smears, mammograms, whether they were admitted to the hospital. What they found was the more engaged a patient is, that's the dark blue, the better they were. The lower their HDL, the higher their HDLs were, the lower their triglycerides were. They were more likely not to smoke. They had less hospitalization. So the higher the PAM level, the more engaged the patient was, the better clinical outcomes they had. So this was the science to prove that we need to engage or have more engaged patients by engaging them with compassion and empathy. So one of the main drivers of patient engagement is, like I said earlier, not just caring for our patients, but caring about our patients. Being compassionate, a compassionate provider, right? Having behaviors of compassion through body language, tone, demeanor, communication is what drives our patient outcomes. And we're going to talk more about compassion in a little bit. So let's talk about the tactics and strategies of connecting with our patients. So, all right, Adam, you said why we should do this. You've thrown a little science at us as to, what the benefits are to being more compassionate and connecting better with our patients. So now tell me how I'm going to do that. So Dr. Moravian is a well-known psychologist who is famous for what's called the 738-55 rule. And that rule talks about how we communicate with somebody about sensitive topics or about, attitude. How can we be more effective in our communication? And they looked at 3 aspects of communication: what we say, our verbal content; our vocal expression, so how we say it, our volume, our tone, our how fast we talk, and then our body language. And actually what they found was, believe it or not, what we say in being an effective communicator is the least important. That's the 7. What we say is 7%. But what's most important is how we say it. So our tone, our demeanor, our volume, and our body language. Actually, the most important is our body language. But when looking at these 3 aspects, right, what we say, how we say it, and our body language, what's the most important is that all of these match, right? So when you're talking to a patient, and you are about to ask them, what questions do you have for me, and you have one hand on the doorknob, that's not encouraging them to ask you any questions, right? So it has to be congruent, right? The body language has to show that you're here to listen. You're not here to, kind of move on to the next patient and hope that the interaction is going to end sooner than later. So what's the secret sauce? Well, patients want us to be timely. They want us to work with our colleagues together as a team, with our office staff as a team. They want quality care. They want you to communicate with them, and they want you to not just care for them, but care about them. So they want to know who you are. They want to know they're in good hands. They want to know that you care. They want to have a voice in their treatment, so not just be dictated to. They want to work with you together on what the treatment plan is going to be. They want to understand the plan, not just walk out of there going, I'm not really sure what just occurred. And they want, help navigating the system and being able to process that care. So this is what they want from you, not just a prescription or not just a treatment plan that they don't really truly understand. So it's finding that balance between the task of being a physician and a provider or clinician and the relationship you need to develop with the patients. They are equally important, and there needs to be a balance between those two. So when we're communicating with a patient, we walk into a room, whether it's inpatient or outpatient, right? There's a beginning when you walk in, there's a middle, and there's an end. And the most important part of that interaction, believe it or not, is the beginning and the end, right? You never get a second chance to make a first impression. And they're going to remember what happened at the end of the visit. Yes, the middle, which is the history, the exam, explaining the diagnosis, super important, but they're really going to get their impression of their interaction with you and their experience with you in the beginning and the end. So their tone and demeanor, how you opened, how you walked in the room, aligning the why of the visit, asking questions, right? Not saying, do you have any questions for me? That's a yes or no question, and they're likely going to say no because they know you're a busy doctor that needs to move on to the next patient. So open-ended, what questions do you have for me? Not, can I do anything else for you? That's yes or no. What else can I do for you? Teach back, right? So let's say I'm a urogynecologist. I see a lot of older patients. I say to a patient, so explain to me what you're going to tell your daughter, husband, what you're going to tell your son happened in today's visit. If in their own words they can't tell me, then they probably don't understand. Not say to them for teach back, so what did we talk about today? That's very intimidating. But asking them how they're going to communicate that to a family member after the visit is over, they should have a fairly understandable idea of what you talked about. So teach back, showing appreciation, thanking them for their trust. These are things that are going to show them compassion, empathy, and that you're not just caring for them, but that you're caring about them. So remember those effects, the primacy effect and the recency effect. Those are important parts of the interaction. We talked earlier about listening, right? Waiting for the period, not cutting them off in the middle. That's part of the courtesy and respect. Listening to what they have to say is don't underestimate that importance. When you cut them off mid-sentence, even though you have good intentions, they don't like that. They find that to be a little bit rude, and they feel that you're not listening to them, right? You're not listening to what is bothering them. So let's talk about empathy. So what is empathy? What is empathy? Well, empathy is a feeling or an understanding of another's emotions, okay? Understanding their feelings. So how do we express empathy? Well, I hear all the time physicians say, I'm sorry. I'm sorry. The patient has a complaint. You say, I'm sorry. Well, I'm sorry kind of indicates to them that you must have done something wrong, right? I'm sorry is sympathy. It's not empathy. When somebody dies, we tell them, oh, I'm so sorry for your loss. Empathy can be, oh, I went to, I went to the pharmacy to pick up my medication and it wasn't there. It wasn't your fault, right? So instead of saying, I'm sorry, say, wow, that must be really frustrating. Or it sounds like you're having a really bad day, right? That's showing empathy, a warm tone, right? Close proximity, a therapeutic touch. These are ways we show empathy. Okay. So what's compassion? Is empathy and compassion the same thing? Not really. We talked about empathy being feeling what they're feeling. Compassion is the action. So compassion is action. Compassion is the action we take in response to that feeling of empathy. So it's what we do, right? So empathy, wow, it must be frustrating. I can only imagine. You put your hand on their shoulder, you take their hand. Compassion is the action we take. So what is one way we can show great compassion with our patients? Well, when we see them, whether it's ambulatory or in the hospital, we sit. Sitting as opposed to standing over our patients, right? Eyes to eyes, heart to heart, helps them feel that you're on the same level with them. It takes away that power differential. It exudes authenticity that you're listening to them. We talked about the importance of listening. And actually, the patient perceives you having spent more time with them. So you could so some providers will say to me, well, I don't have the time to do that. Well, you actually can see your patients for less time if you sit, because many studies have shown that they actually interpret it as being longer. You're less rushed, and it's seen as very empathetic and compassionate. And this was a study showing that when a provider was sitting in the room and stood, and the other one sat in the room and sat, and then the patient was asked, how long did the provider spend with you? 40% more time in the group that sat. So sitting is hugely compassionate. Narrating the care. So what does that mean? Well, we do a lot of compassionate things when we interact with patients. We close the curtain, we close the door for their privacy. Narrate that. I'm closing the curtain for your privacy. I'm washing my hands for your safety. When I'm doing an exam, give them the result. I'm checking your ankles for swelling. I'm listening to your heart. Oh, they sound great. Oh, your ankles are not, there's no swelling. narrate what you're doing to demonstrate that empathy and compassion. Manage up. What is managing up? Managing up ourselves by telling them, what we are. We're a senior member of the practice or whatever. Or managing up our colleagues. Oh, Mary, isn't Mary, our MA, wonderful? Or isn't Sally at the front desk tremendous? Right? Managing up our colleagues exudes a sense of confidence for the patient. We talked about earlier, our goal is to reduce the anxiety of our patients, because in the end, when we reduce the anxiety, they'll be more forthcoming. We'll connect better with our patients. We'll get better clinical outcomes. Well, giving them that sense of confidence by managing up ourselves and our colleagues brings down that anxiety level. Be patient with your patients, right? Don't rush the communication. Patients may not understand everything you're saying. So you have to show them that respect and support and reassure them that you're always here for any questions, right? So try not to, I know we have time constraints and we have to move from patient to patient, but sitting, doing a lot of the tactics that we're talking about allows us to be a little bit more patient with them. Service recovery. Okay, everything's not going to go well all the time. So this is a mnemonic to remember how to deal with a difficult situation or a mistake or something that didn't go exactly the way we wanted it to. Number one, listen. Listen with empathy. A blameless apology is okay. So in this situation, we can say, I'm sorry that this occurred in this way. Without it being your fault, we're happy you brought it to our attention, and we're going to, number one, do our best to solve the problem and make sure this doesn't happen again in the future, either to you or anybody else. But making sure you thank them for bringing it to your attention. So service recovery is hugely important when things don't go well. In fact, most studies have shown that if we do good service recovery in situations that don't go well, they'll actually rate you better than if that untoward incident never occurred in the first place, because they appreciate how you addressed it with them, and reassure them. So service recovery is hugely important. So we talked about, decrease the anxiety, because anxiety typically is a big communication barrier, increases their adherence, ends up improving their clinical outcomes. So that's some of the tactics and strategies. So let's talk a little bit more about the science. So typically in the past, right, there's bedside manner, that's the art of medicine, and then there's the science. You learn the science in medical school. They say, well, the art of medicine, you either got it or you don't got it. Well, we've kind of learned throughout this talk that there are ways to learn to have a better bedside manner, and there's a lot of science to the bedside manner. It's not just the science to the medicine, but there's a science to the art of medicine. These are all studies looking at depression and filling the prescription. And they found that the more compassionate a provider was, the more likely they'd fill that prescription and adhere to that. Hypertension, more compassionate. These are all studies looking at the association of compassion and empathy with these different pathologies. 70% higher chance of adherence to their medicine. Health maintenance. This was an HIV study looking at when the patient interpreted the provider as knowing them as a person and not just a patient, they had better odds of adhering to the therapy, better lab results showing 0 HIV RNA. So these were studies that looked at how when we connect and are compassionate with our patients, we get those better clinical outcomes. This was a physician empathy study measuring high versus low empathy and measuring the hemoglobin A1C, which are levels, and the LDLs. The more empathy we had, the better the A1C was, the lower the LDL levels were. This is direct correlation of these behaviors with the clinical outcomes. So why don't we all do this? Why isn't everybody just compassionate? Well, 56% of physicians say they just don't have the time to do it. They don't have the time to be compassionate. Well, how long does it take? These are about 5 different studies that measured there was an observer going in with a patient, and they looked at how long it took to do one single compassionate thing. And every study showed it took less than 60 seconds. So it doesn't take any more time to be compassionate. Okay, so in summary, these are the what we call the blue six, right? These are the aspects of techniques we can use to be more empathic and compassionate with our patients, right? Frame the encounter, ask open-ended questions, right? Acknowledge that you've reviewed the record, show empathy by listening, by using phrases like it must be or it sounds like, narrating the care, managing up ourselves and our colleagues, sitting, can't stress number five more, and listening. If we can concentrate on these six behaviors, we will be able to learn how to be more empathetic and compassionate with our patients, and in the end, get better clinical outcomes. So I think we're just about on the mark. I hope that this was helpful. I appreciate everybody's time. This is a really important part of patient care. In the end, we can have the best, cranberry pill in the world and iron supplements, but if we can't communicate, with our patients, all of the treatments we have in the world are not going to be helpful if the patient is not going to be engaged in getting themselves better. So I appreciate everybody's time. I hope we have some questions, and I'll pause here.
Thanks, Adam. That was a great talk. Yeah, I learned a lot. It was very, very helpful. I think, beyond just the physician experience, just listening to that and thinking about how I can incorporate those things in my day-to-day, just in general, I
Yeah,
found to be very helpful. So thank you. In
great.
terms of questions, I think some things are coming in right now, but I wanted to share a comment from Naeem. She said, Dr. Holzberg, it's as if you are speaking my mind. Hats off to you. In the West, I feel this is not the case at all. It's more monetary benefits. So that was nice to hear. Um, but yeah, no other questions. If anybody has any questions, feel free to, you can raise your hand, you can ask directly. We can hang on for a minute or two.
Yeah.
Somebody shared this could turn into a podcast and should be heard by students in top medical schools in Canada and the US. Maybe
It is
maybe
being talked.
something to consider.
Yeah, it is being talked about more and more. I think in medical schools around the world. Our residents and our fellows are all the surveys that we have to do on them after they do rotations are all about patient communication. Not all about, but that is one of the aspects of their evaluations. So it is fortunately, this is being talked about more and more with learners. So
That's good to hear. Oh, somebody says you should give a talk about this to students during their white coat ceremony.
appreciate that.
So, you know what? I think if there's no other questions, we can call it a night and just I'll just let everybody know again that there is going to be a replay if you want to share it with your peers or listen to it again. And if you have any questions or comments, you can reach out to me. In the follow-up email, it'd be great for you to share your thoughts. We have a survey there as well. And hold on, I do have a question.
Yeah.
Oh, somebody, did ask a question. So how to dress appropriately during the consultation. Do you have any
How to
thoughts on
dress
that?
appropriately?
Yeah.
So that's a good question. So, there are studies looking at how to dress as a physician. In fact, when I was a resident, this was quite a long time ago. One of our attendings did a study at our institution about how we dressed, and one would wear a lab coat, one wouldn't wear a lab coat, one would wear a tie, one wouldn't wear a tie. And in the end, what most studies find is that how we're dressed means nothing. Um, it's 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 how all the things I talked about. So I can walk in a patient room and probably be wearing, scrubs or even, jeans and a t-shirt. And if I connect with my patient and I demonstrate to them that I not just care for them, but I care about them and I show them empathy and compassion, I don't think they're going to care what I'm wearing. So I don't think there's a right answer to that question. I think it's what we say, how we say it, and our body language that's most important, not necessarily how we look. That's
Hmm.
And I think there's been many studies looking at that aspect. Now, obviously, we don't want to walk in a patient's room with, ripped t-shirt and shorts. But I don't think wearing a tie or wearing a lab coat or just wearing scrubs or,
Mhm.
necessarily matters.
Okay,
I
so we have
hope
a
that
couple more
answers.
questions.
Yep.
Somebody asked, like would a physician walking into the exam room carrying a laptop, do you think that has any impact on a patient's perspective in any way?
So I think in the days, I get this question a lot about the EMR and how to incorporate the EMR when we see patients. So one of the ways I think it's okay if you walk in with a laptop, as long as you perhaps maybe put that laptop down and do a good introduction to that patient about who you are, what your role is, how you're going to help them. Explain to them that it's important to take notes during the interaction so that you can accurately record the visit, and also incorporate them into the EMR, right? So say to them, look, I reviewed your records. Here's your
Mhm.
results. Here's your test. Especially with a laptop, show them what you're
Mhm.
looking at and bring them into part of the evaluation. Then they appreciate, how much you're not just walking in the room and kind of getting in, getting out, but that you're including them in the process. So I think
That's a
that's
good point.
okay as long as you explain it well.
Yeah, it's a great point. So another question here is sometimes you have to pause a conversation to understand a point or redirect wavering thoughts. How would you approach that situation?
Yeah, so you're talking about a patient who's going off on a tangent.
Yeah.
And in those instances, you're going to have to find the opportunity to perhaps interrupt. So in that sense, if it's not related to your situation, then you can politely pause them and say, that's very interesting. I would love to hear more about that, but my priority right now is to take care of the problem you came in for to see me today. I'd love to talk about that more with you another time. There is a polite way to interrupt a patient when they're kind of rearing off to something that has nothing to do with why they're there to see you. So yes, so waiting for the period of the question mark may not be applicable to every situation. But I think, and I'm guilty of this probably more than many, to say that a patient who's explaining to you, how they're feeling or what their symptoms are, and you're like asking the next question before they even finish explaining that to you, that's the difference between listening and not listening.
And on that same top or similar to that topic, another question was how do you end the appointment when a patient is super chatty, but like it's time to go?
Yeah, you can. So if the patient is super chatty and it's getting to the point of not being relevant to what you're seeing them for, you can say, look, I would love to be able to sit and talk to you. As you know, I was trying to do my best to make sure I saw you on time for this visit. I want to do the best for the patient that's after you. So I would love to be able to talk more
Mm.
about this with you. But if you wouldn't mind, I want to give the next patient the same respect I gave you. So can we talk about this more at another time? I think they end up appreciating the fact that you're, ending that because you want to respect their time as much as your time being respected as well. I
Right.
think that's probably one way to do it.
That's good. I like that. So another question from a pharmacy tech is, how do I demonstrate empathy with my oncology patients? When I call them and ask, how are you doing today? It feels a bit ignorant because obviously they aren't feeling the greatest.
Yeah, so that's tough. Um, I mean, you don't. I mean, if you're if you're not face to face with them, then you certainly don't know exactly how they're doing. But it depends on the situation. I mean, if you know to some degree they're at a bad place or they're having a bad time, then you say, look, you don't have to say start it with how are you doing. You can start it with, boy, I can only imagine you must be having a rough day. How can I help with that? Right.
Ah, okay.
I mean, that's as opposed to just say how you're doing, right? So using those, and if you guys want, there's more empathic phrases than just, it must be or it sounds like. If you Google, empathic phrases, in healthcare, you'll find, 50 different phrases that you can use that demonstrate empathy.
Okay. Another question is, how can you deal with family members in the exam room?
Well, the most important part of dealing with family members, number one, is to acknowledge them, right? So when you walk in that room, not just focus in on laser focused on the patient, but walk in and say hello to the patient, introduce yourself, and say to the patient, so who do you have with you today? Because certainly you can't assume who they are, right? I've made that mistake, right? Oh, is this your daughter? No, that's my wife, right? So, so you need to say to the patient, so who do you have with you today? Let them introduce them, say, wow, it's really great to meet you. I'm glad you're here to support your, wife, your mother. And if you have any questions as we go along, please ask. I don't know if that question was being asked as how to deal with them because they're a problem,
Yeah.
which probably was how it was more asked. Um, Look, you have to treat the family members with the same courtesy and respect that you're going to treat the patient. And you do your best to be able to demonstrate that and do the same thing you would do with them that you would do with the patients. But also at any point, say to them, look, I'm here to take care of your mother, and I'm going to direct my patients to your mother unless your mother wishes differently, and then I can direct them to you. You have to handle the situation because they're all going to be individual, and sometimes it's not easy.
Yeah, that's fair. Um, I have two more questions.
Wow,
Very
everybody
simple.
woke up, huh? We have like
I think they did. Yes. It's nice. I was just about to end it,
right.
right? Okay, so simple question. Should a doctor cover his or her tattoo?
I don't think so.
Right? Just show who you are.
Yeah, nothing wrong with the tattoo. I like
And
them.
then,
Ink.
yeah,
Yeah.
okay. And then how extensive should a doctor's self-introduction be to the patient?
I mean, it doesn't have to be extensive as far as time, but it should be well defined. And I'll give you the example of that I give all the time to hospitalists. So hospitalists, I think most of you probably know what hospitals are. They're physicians that take care of patients while they're in the hospital. Um, I always tell it, I work a lot with hospitalists on the inpatient side, and I say to them, look, when you walk in the room and say, hi, I'm your hospitalist, number one, most patients don't know what a hospitalist is. Number two, they think you just said hospice and they think they're about to die. So, you have to define your role. So, I tell them, look, I'm your hospitalist, and what that means is I'm kind of like your primary care provider here at the hospital. I'm going to coordinate your care. I'm going to answer all your questions. I'm going to communicate with the specialist, perhaps a surgeon. I'm the one that, like your primary care physician does on the outside, I'm doing that for you on the inside. And I'm going to be here to answer any questions for you. So it is important that you give your role in their care, and even more important, that you're going to work together with your colleagues in nursing and techs. You all work together as a team. Patients really want a team approach to care, and they want to know that you're communicating with each other. One of the
Mhm.
biggest complaints we see in surveys when they give comments is my doctors never talk to each other. One came in and gave one plan, the other one came in and gave a different plan, or one didn't know the other's plan. So demonstrating that you work together as a team, what your role is in their care, and defining how you're going to help take care of them is very important. Does it have to be 20 minutes? No, you can do that in 2 or 3 minutes.
Okay. And then I believe the answer here is yes, but just to clarify, isn't the word hospitalist used more for ICU, inpatient patients, like the ones that are admitted, right?
Not necessarily ICU. Hospitalists in the U.S., at least I don't know if they're probably, I don't know how much the role of a hospitalist there is in Canada. A hospitalist, and this term is actually disappearing even in the U.S. They're using the term hospital medicine doctor as opposed to a hospitalist. So I really shouldn't even use the term hospitalist, but it is still used a lot. A hospitalist is a physician or a mid-level provider. It could be a nurse practitioner or a PA who are taking care of an inpatient patient, but not necessarily the ICU. It can be, I mean, it can be it can be in any department in the hospital, but it's inpatient, yes.
Okay,
Yep.
awesome. So I think that's it for the questions.
All
Yeah,
right.
a
Well,
good,
good luck in
good
the
amount of
Amazon gift card
time.
to everybody. I guess I'm going to sign off from here.
Yeah,
I'm not eligible to get the gift card. Thank you, everybody. I appreciate the questions. I appreciate you, the comments and you listening. It's a fun topic to do. Obviously, you can see I have some passion for it. And thank you, to Xyle Plus for giving me the opportunity.
Of course. Thank you so much, Dr. Holzberg.
All right, thanks. I'm going to stop sharing here.
All
I'm going to leave. All right, take care, everybody.
right, you too. Have a good
Bye-bye.
night.
You too.